Okay, so the topic is all about management of steroid-associated hyperglycemia. Of course, we're gonna concentrate on the different insulin regimen. So this is the outline. Um, as an introduction, I'm gonna define what steroids can do to the blood glucose of our patient, both with diabetes and without diabetes. Okay. Next is we'll go to the prevalence. How often do we use steroids in the clinical practice, and how often do they develop hyperglycemia? Okay. So the next is pathophysiology and mechanism. Uh, the next is quite important, the types of steroids, especially their glucocorticoid potency and duration of actions. Next is how do we monitor the blood sugar of a patient on steroids, and then management. And after this short talk, we're going to go to the second portion of the uh, program, which is or session, which is the case studies. So let me define to you steroid-induced hyperglycemia. This is a straightforward definition. So steroid-induced hyperglycemia or steroids-induced diabetes is an abnormal increase in blood glucose concentration during glucocorticoid use in patients with or without a previous history of diabetes. Okay, as far as prevalence is concerned, steroids is commonly used in our practice. In one study, steroid use in the hospital may exceed 10%, 40% of which were prescribed for respiratory diseases, musculoskeletal, and as well as cutaneous diseases. Immunosuppression is quite common, uh, malignancy, and neurological disorder. In terms of the duration of steroid treatment, most are less than 5 days, but it can be more than 6 months, and in minority could go up to more than 5 years. Um, it can be given through oral, injectable, topical, and IV form. And IV forms have been shown to be the most notorious in terms of causing hyperglycemia. Okay, so as far as the prevalence and predictors of corticosteroid-related hyperglycemia in hospital patients, uh, we can see that in patients receiving high-dose steroids, in terms of frequency for both patients without diabetes and with diabetes, it is significantly increased. So what is the definition of high-dose steroids? These are patients receiving high-dose steroids equivalent to 40 milligrams per day or higher of prednisone or its equivalent of steroids for at least 2 days. Okay, so what are the equivalents? Down there, you see 40 milligrams per day of prednisone is equivalent to 160 milligrams of hydrocortisone, 32 milligrams of methylprednisolone, and 6 milligrams of dexamethasone. In our current pandemic, very common in patients with COVID-19 infection with poor O2 sat are receiving dexamethasone 6 milligrams daily IV for about 5 to 10 days depending. And in diabetic patient, we expect an exaggerated hypoglycemia since 6 milligrams is considered a high dose steroids. So what are the risk factors? These are some of the risk factors listed, but for me, the most important is the 1, 2, 3, dosage and type of steroids, the duration of treatment, and the age of the patient. And of course, all of these are factors, especially in patients receiving um, immunosuppressant agent like cyclosporine and uh, uh, tacrolimus. Okay, so what are the mechanisms? So, studies have shown that the steroids can cause hyperglycemia through multiple mechanisms. It can reduce uh, pancreatic insulin secretion. It can increase in hepatic gluconeogenesis. It can reduce insulin sensitivity in the peripheral tissue, liver, muscle cells, and adipose tissue. And more importantly, in addition, impairment of incretin effect. So the glycemic effect of a shorter acting steroids is exaggerated in fed state compared to the fasting. So you would expect a marked postprandial hyperglycemia. Okay, so this is the different types of steroids, the dose and the glycemic effect. So hyperglycemic effect is influenced by the glucocorticoid potency as well as the duration of action, route of administration, and duration of use. As you can see, hydrocortisone in terms of its glucocorticoid potency is 1, followed by prednisone 4, followed by methylprednisone 5, and you can see dexamethasone 30 to 40, meaning 30 to 40 times more potent compared to hydrocortisone, and about 10 times more potent than prednisone in terms of its glucocorticoid effect. And these are the onset, peak, and resolution. Okay, and you can see prednisone and methylprednisone, so the same onset, peak, and resolution for 8 hours and 12 to 16 hours. And you can see dexamethasone as the longest resolution time, and it's 24 to 36 hours. So after discontinuing dexamethasone, you can still see or see the hyperglycemic effect for quite sometimes even after discontinuation. So the reason for the use of MPH insulin at a time of glucocorticoid dosing is because of its pharmacokinetic effect. Okay, you can see down there the green, that when you dose NPH insulin together with glucocorticoid dosing, you can see the pharmacokinetic effect of MPH is similar to the hyperglycemic effect of glucocorticoid. Okay, so the although the effect is opposite to that of glucocorticoid, and therefore can be used as a to counteract the deleterious influence of steroids on glycemia. In most instances, MPH insulin has an onset of action of 2 to 4 hours, the peak plasma concentration at 6 to 10 hours after dose administration, and a duration of action of about 10 to 14 hours in most situations. So, in other words, when MPH insulin is administered concurrently with steroids, either methylprednisolone or prednisone, short-acting one, it may be especially effective for inhibiting the hyperglycemic effect of short-acting steroids once daily. The NPH insulin may be added to the patient's existing glucose-lowering regimen and continued to as soon as the glucocorticoid is discontinued. And this method of dosing allows the effect of MPH insulin dose to wear off as hyperglycemic effect of the glucocorticoid dissipate, and therefore minimizes the risk of hypoglycemia for the patient. So how do we monitor? Here's some of the guide. Initiate blood glucose monitoring for all patients on steroids before meals and at bedtime every 4 to 6 hours if MPO. Now, discontinue blood glucose monitoring in patients with no history of diabetes if the blood glucose is less than 140 for at least 24 to 48 hours. If the blood glucose target on therapy for majority of non-critically ill hospital patients is pre-meal is less than 140, and postprandial or random blood sugar of less than 100. Okay. So in patients with no history of diabetes, if all blood sugar is less than 140 for 48 hours, discontinue monitoring. If blood glucose is 140 to 180, start correctional insulin if more than 20 units required in 24 hours, or 2 or more blood glucose reaches more than 180, we must start with MPH or basal bolus. If once daily prednisone the advice is the recommendation is use MPH alone. Okay, if using basal bolus can start with 0.3, 0.4 units per kilogram day as a total daily dose. How about pre-existing diabetes though? So discontinue non-insulin agent. This is in hospital. Difficult to adjust oral or non-insulin injectable in parallel with steroid tapering. In type 1, continue basal bolus with up titration. If in pumps, may require changes of daytime. This is insulin carbohydrate ratio. They usually compute this. In type 2 DM, on insulin or poorly controlled on orals, use MPH or basal bolus. All depends if it's once a day or twice a day or long acting or not. If an insulin naive, can start with weight-based dosing, 0.3, 0.5 unit per kilogram per day as the total daily dose using basal bolus. In type 2 DM, well controlled with the lifestyle or no insulin medication, start with correctional insulin. If it's not adequate, then move to MPH or basal bolus. So these are the tips for glycemic control with steroids. IV insulin infusion is often the easiest, but if patient will be eating and monitoring will be intense. Steroids disproportionately affect prandial insulin requirement. Typically, a patient daily insulin requirement is equally divided between basal and prandial. That's 50-50%. Steroid patient may have higher prandial requirement. It's about 60 to 70% of the total daily insulin requirements versus the prandial or the basal. So one study looking at the difference of MPH versus glargine, it's a retrospective study of 120 patients receiving prednisone 30 milligrams, 60 patients on NPH, 60 patients glargine, equally divided. Similar mean fasting plasma glucose, mean daily blood glucose, and number of hypoglycemic episodes. Total daily insulin requirements, however, is lower in MPH cohort. Okay. Okay, so another study looking at the difference between MPH versus glargine, a study of 20 patients with CF-related diabetes, that is cystic fibrotic patient receiving IV methylprednisolone after transplant. All patients received glargine plus premium lispro, basically basal bolus insulin regimen, and half of these patients, that's 10 patients, received on top of basal bolus and MPH at the time of the methylprednisolone administration. As you can see, the result of the study shows that the group that received additional MPH have significantly better glycemic control over the group that received only basal bolus insulin regimen. Or advantages of MPH. The advantages is it can continue baseline insulin doses while tapering MPH with the steroids taper. Fewer insulin injection if patient not already on basal bolus at home. However, there is slight disadvantages. Okay, need to dose BID twice a day on a dexamethasone because it's a long-acting. MPH must be dosed at the same time as glucocorticoid. Okay, so these are how to dose MPH. It can be added to existing basal or basal bolus regimen or alone with rapid acting bolus insulin. Dose frequency depend on dosing schedule of glucocorticoid, and these are the proposed dosing. Okay, it's so easy to memorize. It's equivalent. Just move the decimal point. If the prednisone is 10 milligrams, use 0.1 unit per kilogram. It's a weight base. 20 milligrams, 0.2 units per kilogram, 30, 0.3, and so on and so forth. Okay, but up to maximum of 0.4. Okay, there's another regimen that we can use that is recommended, especially if you don't have MPH or the institution or the hospital is no longer using MPH or it's no longer included in their formulary, like in our institution. Okay, so you can use modified basal bolus. And what is this? Okay, this is a study looking at retrospective study of 58 non-critically ill patients on DM receiving average equivalent of prednisone 30 milligrams daily. Now, patients who received normoglycemia, average daily dose of insulin approximately 0.8 unit per kilogram, so 30 to 50% basal and 65 to 70% prandial insulin. So therefore, modified basal bolus instead of 50-50 basal bolus, this is more on bolus on the prandial. It's about 60, 70 to 40, 30 to 40% basal. So you more impact on the prandial because of the impact on the incretin effect of steroids. Okay, so the data suggests that non-critically ill patients with hyperglycemia receiving steroid require a higher percentage of total daily dose insulin therapy as nutritional insulin to achieve normoglycemia. I repeat, the modified basal bolus instead of 50-50, it's 60-40 or 70-30. 70 majority, higher percentage for prandial than basal. So how do we discharge patient after treating and after discontinuing the or tapering the steroids? How do we discharge them? No? Now, structured discharge plan should be created. Clear insulin dosing schedule, outpatient follow-up, not too long, not so long. You have to follow them up about 1 to 2 weeks. No, if steroids are stopped abruptly, patients should return to pre-admission regimen, assuming they have a good glycemic control before admission. Okay, if discharged with the steroids taper, insulin should be reduced in proportion, decrease total daily dose by 10 to 20% with each 20% increase in glucocorticoid dose. And that's the end of the introduction. So after this, we will now proceed with the case studies.